I'd like to introduce Steve Bell. Well, everyone knows him by now. I'd like to ask Steve Bell to come up for his presentation.
Thanks, Sarah, and good afternoon, everyone. You'll see I've gone corporate. I have to go corporate, don't I? It's a good job I had it in my suitcase. So I'm going to talk about transforming MND care. And it's a resource that we've developed in the MND Association for health and social care professionals to benchmark and improve their services. And of course, it's their services for people affected by ALS and obviously caregivers. I think one of the backgrounds we've got to understand here is that certainly in the UK, we're working constantly now in a system of austerity, where statutory services, our health services and our social care, are pushing back on the funding of care, pushing back on the provision of care, and we see an increasing postcode, zip code lottery of you can access care in some areas, but not in others. So, back in 2016, the National Institute for Health and Care Excellence, known as NICE, published a guideline on motor neurone disease. This was the culmination for us of years and years of lobbying to actually get a cohort of people to put together defined standards of care and pathways of care for people living with MND. And this is sponsored at government level. Sadly, it's a guideline. It's not necessarily enforceable, but NICE, being a sort of quango of the government, has some quite serious impact, and we can really use this for our campaigning and influencing. So we got our guideline. We're the rarest disease to have a guideline, which really does show sort of the impact. And as I say, it talks about the assessment and management of MND as a condition. But that's fine, but how do we else hold services accountable to implementing that guideline? We've had so many turn around and say, well, it's only guidance, we don't have to follow it. But we really wanted to be able to enable professionals to collect and analyse data from their services against the standards in that guideline, so that areas for improvement could be identified and actions taken. We fund, as many of you will know, 22 care centres up and down England, Wales and Northern Ireland at the cost of £1.2 million a year. We're developing an affiliation model, so we're not likely to expand our care centre programme, that's about as far as it can get, but we want to recognise good quality practice of care in areas, so whether it's multidisciplinary care or whatever. And the development of this tool, the Transforming MND Care Audit, allows services to demonstrate to us that as far as possible they are fulfilling the requirements of the NICE guideline. So it's based on a system of clinical audit. So we ask the services to, and we've just started in the process of this, all our 22 care centres are meant to be at least on the way now by the end of December, either committed or completed the audit, and many already have, which is very, very encouraging. We also have a number of services elsewhere that have started doing this, so whether it's elements of services based in hospice care, palliative care, in multidisciplinary teams, or whether even it's virtual teams. So we collect data, a very typical clinical audit cycle here. We analyse data. That generates a development plan. We oversee the implementation with our field staff, the regional care development advisors, to ensure that the implementation of that improvement plan is enforced, and we obviously re-audit and will be re-auditing every 2 years. And the good thing we want to be able to do out of this is actually share practice as well. What is different in different areas, and how can areas, by networking them together, learn off each other and develop? So some of the benefits of this model, which I'm going to describe in a few moments, some of the benefits to professionals. It allows them to benchmark their current performance. It shows what they're doing against our NICE guideline that's compliant with the guideline or that helps need improvement. It establishes where best to focus efforts to improve the outcomes for people with MND. So on the ones we've seen so far coming back, it's telling us that people pretty much have good access to non-invasive ventilation, to dietary support, but very, very few people are having aspects of cognitive change assessed at diagnosis and as the disease progresses. And it's not insignificant that as an association we're currently halfway through a 2-year programme that we're funding with Professor Sharon Abrahams of Edinburgh University on the rollout of the Edinburgh Cognitive Assessment Scale tool. It will help people plan cost-effective improvements. It's going to help improve professional practice and certainly improve multidisciplinary working and communication with other partner organisations. So what's the process? How did we arrive at this tool? We put a project team together based on association staff, and Gudjon will be really pleased to hear this because I've always been conscious of Gudjon's comment about nothing about us without us. We had patient and carer representatives on this group helping us develop the tool. We had a clinical reference group based from professionals across England, Wales and Northern Ireland. The tool, the NICE guideline, certainly applies in England, but we have commitment from both Wales and Northern Ireland to implement this in both those devolved legislative bodies. We piloted it with 5 sites, each representing a different model of care. So one of our own care centres that's based in London, a care network which stretches across the whole of South Wales, a multidisciplinary team just with a funded coordinator in North Wales, a community neurological team in Sussex, and a virtual multidisciplinary team in Cheshire. So here's the structure, 2 parts to it. We have an Excel-based audit on one side that is completed by professionals. So they score themselves by looking at the records of people with MND that they hold against the requirements of the NICE guidelines, so on nutrition, on time to diagnosis, on access to multidisciplinary team. But running alongside that, we have a care experience survey that is completed by people with MND and their carers in that area. And that's addressed by a logarithm that identifies the number of people with MND and carers that we want to be asking what is their experience of the local survey compared to the opinion of the local care professionals. Both those two come in, so the audit comes in from the professionals, the survey comes in from people with MND and their families, and an improvement plan is generated. So we have a summary graph here that just shows really some of the aspects of what it is we're asking. You'll see an orange line, which is a benchmark, which is set at around about 80%. And I know you won't be able to read the parts at the bottom, but the first column is on recognition and referral. The second one, are you given information and support at diagnosis? Cognitive assessment. You'll see a whole gap there, though, for this one service that undertook this survey where there's 0%, and that was about planning for end of life. So there was one particular service that did not ensure planning for end of life for people with MND. You can see this shows them areas of where services are really, really good, but where there's room for improvements. That's just one typical summary graph. So here's the improvement plan, and it's evidence-based, and this talks at the side about information and support at diagnosis needing improvement, psychological support needing improvement, and management of muscle problems. Absolutely fascinating that Dr. Sané commented about the caregiver, because we had one service here who said actually no carers at all, no caregivers were eligible or offered a carer's assessment. So we might be providing services for the person with MND, but the carer was in a position of burnout. One of the other things we can do is actually, that the tool does, is it combines findings from different services. And so this really begins to give us a state of the nation approach that we can use at government and regional level. So for instance, this one, the top one there on the audit that's in red, it's a RAG system, red, amber, green, shows that only 28% of people got to see a neurologist within 4 weeks of the referral rate. I mean, the guideline says that should happen, and it's not, 28%. So it gives us an opportunity to go back and follow through at government level. There's one down at the bottom. Has the carer been informed how to access a carer's assessment? Hugely low at 32%. You know, that's 2 out of 3 carers basically who are not offered an opportunity for an assessment. And yet what we know is compared to carers in the UK who care on average for 60 hours a week, our carers are people with MND. It's either continual 24 hours a day or certainly more than 100 hours at a time. So this generates the improvement plan and it gives us a state of the nation. We're happy to share the tool with you. It's emerging. We're currently going to review it in January. We're halfway through that review. And one of the things that we've been pleased to find out this year is that NICE, so the people who set the guidelines, have got the ability to actually endorse the tool. There's a few tweaks they want us to make, and we're currently working on those. But not only will we have a nice guideline for MND ALS, we'll also have a transforming care audit tool that will be recognised across England, Wales and Northern Ireland. If you want to find out more about the tool, visit our website. There's the link, and come and see me afterwards if you haven't got time to copy that down. And thank you for listening.
Time for questions?
Rob's over there, isn't he? Rod.
Wait.
Sorry?
What's the performance level that scores green?
Scores green, you're looking at 80% compliance.
Steve, the one question I would ask is, this is an awesome set. Is this the first time that the organization has done this extensive type of research, or has this benchmark against? I saw the benchmark line. I didn't know if that was a goal you had set, or if that was based on previous similar audits, or is this better or worse, I guess, is the question I'm asking.
Okay, thanks, Rob, for that. So we've previously established and set our own standards of care that we devised and defined ourselves. We've measured our care centres. When they apply for funding from us, they have to measure themselves against those standards of care. But given now that there is government guidelines on how MND should be addressed, you know, those pathways of care and defined pathway, standards of care from the NICE guideline, then this tool has arisen out of the NICE guideline, and it's the first time we've been able to do it with significant backing. So the NICE guideline gives us the backing to be able to do this. Yeah.
Steve, sorry. So I understand the process. Was this developed by the MNDA, and then you went back to the government and said, we'd like to show you the results, we'd like you to do something with this?
Yes.
Or did they buy on it initially?
No.
I see.
We initially put this together through that reference group that we were talking about, and then we found out that sometimes NICE will work with us, not with us to develop, but will work to endorse an assessment tool. So NICE haven't been part of the development of it, but they've been there to comment on it and to shape it in a way that they will be happy to endorse it.
I want to make a comment. Very nice presentation. I've been always thinking about the way for early treatment. I see there's a window here. You don't have a lot of patients, like 28%, going for the neurologist after being referred to. I mean, this is a window that you could work on the early prevention, because I felt in our experience working with the patients and their advocate, we felt that vitamin D and magnesium may have a really important role to play. Okay. And if we only wait for clinical trial, treating the patient already with ALS, you're never going to find out whether that can have a preventative purpose.
Sure.
So
Yeah.
Thank you very much.
Good point. Thank you.
Yes. Have you inquired into how you will, in the future, address the flat line, actually, in the death column?
Yeah, so that will come out in the improvement plans, and if people want to become our affiliates or continue with our care centre funding, then they're going to have to demonstrate to us progression against those areas. So it's a two-part sort of system. It's not as necessarily we're in a sense holding people to account, as we rightly should, for our fundraised income. But I mean, the key drive is improving the quality of care for people with MND ALS. So yeah, that is the whole purpose. We can then go back to commissioners where we say, look, this aspect of your care is really, really good. But actually, in order to address the full need of people with MND, you need to address this, or you're going to get people admitted into acute beds, you know, such a high cost. It gives us such a wide range of opportunity to influence service development and delivery.
But you're also speaking of, I think, of addressing with those living with ALS, MND, the potentialities and possibilities and the realities around choices and possibilities, which death is part of the conversation.
Sure. And so the other thing that we've developed is a very little small card for people with MND and their caregivers to carry around in their pockets that highlights the key recommendations of the NICE guideline that they can carry around and actually challenge services when they go for appointments and say, look, NICE says I should be getting this. So, I mean, they're the biggest advocates of the people with MND themselves.